All right, if you're a PA student, listen up because this is one you absolutely have to know inside and out. Dilated cardiomyopathy. Seriously, this is a super high-yield topic for your PANCE, and more importantly, it's a critical condition you're definitely going to see in practice. So let's break down everything you need to know. So what exactly is dilated cardiomyopathy? Well, at its heart, no pun intended, it's a disease where the heart muscle just gets sick. The left ventricle, the main powerhouse pumping chamber, it gets stretched out, the walls get thin, and it just can't squeeze effectively anymore. And here is the magic number you have to burn into your memory. The LVEF, or left ventricular ejection fraction, drops to 40% or less. That is the official cutoff for what we call heart failure with reduced ejection fraction. This number, this one is pretty sobering. 50%. That's the 5-year mortality rate once a patient starts showing symptoms. This one stat tells you everything you need to know about how serious this condition is. It's a big deal, and it's why our management has to be on point. Okay, so here's our game plan. We'll start by defining the disease properly. Then we'll dig into what causes it, how you're going to spot it in a patient, and the steps to lock in that diagnosis. And then we'll wrap up with the absolute cornerstones of treatment and what the long-term picture really looks like. Sound good? Let's get into it. First step, defining the disease. Now, I want you to think of DCM less as a single illness and more like a final common pathway. It's kind of what happens to the heart after a whole bunch of different insults, and they all lead to this one place, a weak, dilated heart, aka heart failure with a reduced ejection fraction. Let's put some numbers on this, shall we? In the US, DCM hits about 36 out of every 100,000 people and leads to about 10,000 deaths a year. Now, pay close attention to this disparity. It's important. Black patients are affected 3 times more often than white patients. And that brings us to genetics. Somewhere around 1/3 of all cases actually run in families, which is exactly why taking a super detailed family history is an absolute must. So what actually causes the heart to get into this state? Well, the list of culprits is long. It's incredibly diverse. And figuring out the why is a massive part of your job, because guess what? Some of these causes are actually reversible. Okay, this is a great slide to screenshot for your differential diagnosis list. A lot of cases are idiopathic, meaning we don't know the cause, or they're genetic. But look at all this other stuff. For your PANCE, you've got to zero in on the toxic causes. Chronic alcohol use is a classic. Infectious causes like HIV and myocarditis, also super high yield. And get this. Even a heart that's just beating way too fast for way too long can literally wear itself out. That's tachycardia-induced cardiomyopathy. And it's cool because if you can fix the rhythm, you can often reverse the damage. All right, so now we know what it is and what might cause it, but what does the patient with DCM actually look like when they walk into your clinic? This is all about recognizing those classic signs and symptoms of heart failure. Now, here's the key thing to remember. This almost never happens overnight. The classic heart failure symptoms, shortness of breath, swelling in the legs, they tend to creep up on people really gradually. And that's why your history taking is so crucial. You have to ask those probing questions like, hey, can you still make it up that flight of stairs without stopping? What about a year ago? Now, on your physical exam, you're basically hunting for signs of fluid overload. You're going to listen for rales, those little crackles in the lungs. You're going to look for an elevated JVP in the neck, which tells you pressures are high. But the classic high-yield finding you have to train your ear for is the S3 gallop. It's that extra heart sound, that lub, dub, dub. That is the absolute hallmark of a dilated, failing ventricle, just struggling to deal with all the blood coming in. Okay, you have a pretty strong clinical suspicion. Now what? Let's walk through the diagnostic toolkit you're going to use to confirm DCM and, just as importantly, rule other things out. The workup follows a really logical path. You'll start with labs, checking a BNP or NT-proBNP. Those are hormones the heart releases when it's stretched out. Then you'll get an ECG and a chest X-ray to look for more clues. But the test that truly seals the deal, the one that gives you the definitive answer, is the echocardiogram. So what are you looking for on those initial tests? Well, on the ECG, sinus tachycardia is pretty common, but the classic board question answer is often a left bundle branch block, or LBB. On the chest X-ray, you're looking for 2 main things. 1, a big, baggy heart shadow, that's cardiomegaly. And 2, signs that fluid is backing up into the lungs, like pulmonary congestion or pleural effusions. And look, I cannot stress this enough. While all those other tests give you vital clues, the echocardiogram is the gold standard, period. It's the test that lets you literally see the heart, see the LV dilation, and directly measure that low ejection fraction. It's what confirms the diagnosis. Now, for the most important part. What are we going to do about it? When you manage DCM, you are managing heart failure with reduced ejection fraction. And today, that means using something we call guideline-directed medical therapy, or GDMT for short. Modern heart failure therapy is built on these 4 pillars. Every single patient with DCM and an LVEF of 40% or less should, if they can tolerate it, be on a medication from each of these 4 classes. That means an ACE inhibitor or an ARNI, a beta blocker, an MRA like spironolactone, and an SGLT2 inhibitor. These aren't just for symptoms. These drugs have been proven time and again to save lives. Knowing what to use is only half the battle. You also have to know what to avoid. While we're piling on those 4 pillars and using diuretics to help with symptoms, there are some drugs you need to stay away from. And here's a classic exam question for you. Avoid non-dihydropyridine calcium channel blockers, like diltiazem and verapamil. Why? They can actually weaken the heart's contraction and make the heart failure worse. So, beyond medications, we've got devices. For patients with a really low LVEF, we're talking 35% or less, we start thinking about an implantable cardioverter defibrillator, or ICD. This is to protect them from a deadly arrhythmia. And if that same patient also has a really wide QRS on their ECG, especially with that LBBB pattern we talked about, we consider cardiac resynchronization therapy, or CRT, which is a special pacemaker that helps the ventricles beat together, more in sync. Finally, let's talk about the long-term view. Once a patient is diagnosed and they're started on therapy, what can they expect? And what can you expect?
This is such a key concept. Not all DCM is created equal. A patient's prognosis really depends heavily on what caused it in the first place. Some types, like the kind that can happen around childbirth or after a period of intense stress, actually have a pretty good chance of recovery. But others, like those caused by infiltrative diseases or certain chemo drugs, well, they have a much tougher road ahead.
So, beyond the heart failure just getting worse over time, the 2 big complications you're always watching for are lethal arrhythmias and blood clots. Think about it. With blood just kind of sloshing around in that big baggy ventricle, it becomes a perfect spot for a clot to form, which could then travel and cause a stroke. This is exactly why we use anticoagulation in patients who also develop atrial fibrillation, or if we can see a clot on their echo. Okay, let's end with a quick case to put it all together. Your patient has DCM, an LVEF of 30%, and their QRS is wide at 160 milliseconds with a left bundle branch block. Based on everything we just talked about, what 2 devices should be popping into your head right now? If you're thinking an ICD to prevent sudden cardiac death and CRT to help the ventricles beat in sync, you absolutely nailed it. That's a perfect real-world application of these guidelines.